Hello, good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome all of you to today's Research and Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We have a great topic for us today. One of our collaborative research centers, S4A, will be talking about using predictive modeling to identify patients who need social services. Before we get started, we'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation, and we'd like to remind everyone that at any time during the presentation, please do type your questions if you have any in the chat box that you can find on your screen. So without further ado, I'd like to introduce our presenter for today, Dr. Joshua Best, who is a health services researcher with interests in organizational determinants and effectiveness of health information technology and systems, specifically the adoption, utilization, and policy issues of technologies that facilitate the sharing of patient information between different organizations. Josh is widely published, and his work has employed a variety of research techniques, from large-scale database analyses to geographical information system mapping, survey research, to qualitative focus groups and interviews. As a former local public health practitioner, Josh has a particular interest in effective public health information systems, including the role of information technology governance structures on local public health departments' adoption of information technology and systems, the structure of state and local public health information systems, as well as an evaluation of email intervention to improve disease notification efforts. So with that, I'd like to turn it over to you, Josh.
So, howdy. Thank you all for having me share some of our findings and work. And I'm going to be specifically talking about using predictive modeling to identify patients who need social services. And we will try to unpack that statement a little bit as we go through this. But before we begin, this work is funded by the Robert Wood Johnson Foundation through the Systems for Action National Coordinating Center, and we definitely thank them for their support in this. I have representing both Indiana University here in Indianapolis, as well as the Regan Street Institute. And this is a large project, as most of our research work is. It's, a cast of thousands contribute and help out. And these are some key people who, without their support, both at Indiana University and in our partner health system, this project couldn't have occurred. I will also note that up there at the top right, some of this research I'm going to share has just recently been published in the Journal of the American Medical Informatics Association, and that link to their that publication's up there as well for those who would like to see it. So we're going to start with predictive modeling. And for our purposes, we're going to keep the definition fairly simple in a healthcare context. We're looking at statistical approaches to identify patients that are at high risk, or by high risk we mean they're more likely to have negative outcomes. And predictive modeling, this is an oversimplification, but basically we're talking about general approaches that have some sort of algorithm. We have some sort of black box that we're going to do some sort of statistical processing through. And this can be a variety of different techniques, but we just have some sort of thing we call an algorithm. And in healthcare, generally what we predict out are things like utilization, just how many visits will somebody have, or will they come back for a visit. We are frequently use risk prediction to identify patients who have high costs. A classic use of risk prediction modeling is death, right? We're identifying the folks who are at the highest risk for death. So those are kind of the outcomes that we typically look at. And generally what goes into these risk prediction models are data around diagnoses and utilization. That's the kind of stuff that generally is our inputs that we go through. Now, prediction modeling is widely applied in healthcare. Here's a couple of examples from some recent papers that have gone through. one talking about using it to segment patients out, and another talking about hospital readmission production. But generally the idea is that this is a widely used practice in healthcare systems with a good degree of success in these areas. Now, even though it's widely used, there are some limitations with current predictive risk modeling. One, I'll talk a little bit first on the right-hand side of this graphic. You know, as I said, we predict frequently utilization, cost, death. Those are important outcomes, but I would call them or label them frequently as too late outcomes. You don't have a lot of time for intervention at those stages when somebody is already going to cost you a lot or the risk of death is very high. They're a little less proactive thinking applications versus reactive to an extent. And while those are really important things to look at, knowing that somebody's going to cost you a lot doesn't exactly immediately tell you what kind of services that person should receive. That is not what that model and predictive model is telling you it should do. So that's a couple limitations on the outcome side. And on the other side, generally we're limited on what's gone into algorithms. We've been mostly limited to claims data, or now more folks are putting in data from the EHR. Generally, we omit social determinants of health. The things that actually drive health and are important to health don't go into algorithms for the most part. And often these have been single-site data projects. The predictive modeling leverages the data from a single health system or from a single organization. And so that's an important but incomplete picture of the patient's health. So with this study, we had a couple of objectives, and the first one is to evaluate predictive models that use a combination of clinical, socioeconomic, and public health data. So I'm going to step through this a bit, but what we are going to do is we're going to change, what we're going to do with this is we're going to change both the left and right side of this slide with our current project. And the first way we're going to talk about is changing the data that goes into it. So we are going to include data on utilization and health. That has to be there. We're going to leverage all of our good standard number of encounters and diagnosis. That will go into our predictive models. But we're also going to add information that are actually about the drivers of health. We will add socioeconomic and neighborhood contextual data based on where the patients live. We also have neighborhood health context data, things about, as you could things that fall in lines of like average mortality rates in the area, life expectancy, information on smoking prevalence from the particular area as well. So we're going to put all those things that kind of drive the context of health and the context and the real drivers of health status. And then we're going to try to go for a comprehensive patient view. We're going to leverage health information exchange data to get health behaviors and encounters and diagnosis from the entire community of providers. So we're not looking at a single site. We're not looking at the information that a single site can provide, but we're going to leverage everything we know about patients as they travel across multiple providers to seek care, and over time as well. So we adopted this framework by a review by Braveman and all in the annual review of public health from a few years ago to kind of help organize our framework for thinking about what should be fitting into our predictive models. And if you think about what health is a product of, it's a product of medical care, personal behaviors, living and working conditions, and then the broader socioeconomic opportunities and conditions. And we really like this. And so our goal was to try to tick all these boxes because, as we've outlined already, most predictive modeling only lives in the medical care side. That's where most of their data are available. Most of it is coded and structured. That's what can be used. That's great, but we're going to try to add more personal behavioral data. We're going to add in the living and working conditions, and we're going to add in social and economic opportunities and resources with our approach. And then the second approach is not only are we thinking about what goes into these models differently, we're hopefully thinking about what's a different and new application of the outcomes of these models. So we're going to look at the contribution of these data on the novel outcomes of referrals to social services. And when I talk about social services, what I'm talking about, I'm just saying referrals to social workers, mental health, nutrition, financial counseling, medical legal partnership. We're going to be looking at those type of outcomes. And in fact, these have been coming much more common across health systems. Mental health has a long integration with healthcare, but in response to the changing payment strategies and the push for population health and the emphasis on prevention and avoiding costs, many health systems are increasing their staffing of social workers to address social determinants of health, nutritionists to help give patients better diet, doing pharmacy counseling so people know how to use their respiratory. They actually may give them financial assistance or institute patient navigators. Or now medical legal partnerships are growing in popularity for people to be able to help address housing issues or legal difficulties. So we're going to try to support the more effective and referrals to these type of organizations with our modeling. Or providers, I should have said. I'm sorry. Now, so just to recap our two objectives, we're going to evaluate predictive models that use a combination of clinical, socioeconomic, and public health data. And we're going to see about the contribution of these data on the novel outcome of referrals to what we broadly call social services. So our approach is fairly straightforward. We're going to develop risk prediction models with the clinical data only, and then we're going to develop them again with the clinical data and the community level socioeconomic and public health indicators and do the comparisons. So our setting is in Indianapolis, and actually very specifically is the Eskenazi Health Care System. It's their outpatient clinics. Eskenazi Health, the hospital is up there to the right for you to see. And I apologize, the PDF has kind of overlaid some of the data description of these patients, so I apologize for that. But it's the Indianapolis urban area safety net provider. It is a public hospital system. They're also an FQHC that operates 10 clinic sites across the metro area. Very importantly for our study, all of the social services we're talking about, social work, dietitians, medical legal partnership, financial counseling, they are all offered in-house by Eskenazi Health staff. Several years ago, Eskenazi Health decided that they wanted to not refer out for these services anymore, but brought them all in-house. So we're referring within the organization always. We have a sample of about 84,000 adult patients who had at least one outpatient visit over a 5-year period. Safety net population, so the prevalence of disease and disease burden is relatively high. We have higher prevalence of diabetes in this population than you would in most. For example, the adult prevalence is about 20% here in this community versus much lower in other places as well. And we're going to be working with a very diverse population. Only about 25% of the total sample is non-Hispanic white, and it's also a largely female sample, about 2/3. So what are our data? Well, we're going to be measuring referrals to the following 4 services: social work, dietitian, and mental health. Because the other services were in sufficiently low frequency, we had to lump them all together to make the models work. But so it's just all other services. And our data come from multiple places. We're going to use the Eskenazi EHR billing and registration systems to do encounter data. That's going to include kept, missed, canceled appointments. And so when we go out to do our prediction of should somebody get referrals or not, we're not looking at only people who got referrals. We're even going to be able to pull in the people who had canceled and missed appointments. And then we're also going to leverage unstructured EHR orders and notes in order to find all of these data points. So let's kind of step through our model again, and I'll try to outline where our data are and come from. So for the medical care side, we have diagnoses as you would expect: asthma, kidney disease, COPD, the list that you would expect, the high-end, high-prevalence chronic diseases. We have number of visits, we have primary care visits, we have diagnoses of mental illness. On the personal behavior side, we have smoking status, and we have histories of substance abuse that's going to come both from the EHR. All of these data, will come from our EHR and from our Health Information Exchange. The Indiana Network for Patient Care is our Health Information Exchange. It is the U.S.'s largest Health Information Exchange, started back in the 1990s by the Regenstrief Institute. Right now we have over 80 hospitals' medical records. It is giant. It's about two-thirds of all patients, or two-thirds of all people in Indiana are included in the INPC. In the Indianapolis metro area, it's something close to 98% of all individuals are there. We have a wide variety of data on many clinical indicators, but this is one of the largest and oldest HIEs in the world. So we're going to be drawing on that. So when I talk about a clinical indicator, it doesn't matter that it was recorded at the Eskenazi outpatient clinic or not. Anywhere that this patient had a diagnosis or type of encounter is included in our model. For the other areas, what we're looking at in terms of living and working conditions and socioeconomic areas, we pull a whole bunch of data based on the census tract that are linked by geolocation. So all of our patients are geocoded to an XY coordinate in the INPC and in our EHR, and we are going to link them back to area prevalence rates that we got from the Marion County Health Department and from our other data provider partners on campus that can talk about mortality rates, infant mortality rates, the prevalence of smoking, surveys that ask about perceived safety for their neighborhood. But we also roll in everything as you would expect too on socioeconomic status for the area, income, education rates, employment rates. We also put in measures of social capital such as voter participation and safety and crime indices. So we roll all of these things into our model. This is another framework that we use. Since I haven't listed everything we do, we pulled this from the Kaiser Family Foundation. I like this as kind of a nice organizing bucket for the social determinants of health. We made a very systematic attempt to check all of these categories and all of these different indicators to come through and talk all the way from stability, the physical environment, education, access to food, the neighborhood context, and the healthcare system. All of these, we have indicators that go into all of our models for this. So here's a schematic approach to how we went through this. We take all of our data sets. We go through a pre-processing thing to clean them up and set them out. We are going to add 41 variables that fall under the clinical data side, and we're going to add 48 variables that fall under the socioeconomic/public health arena. We're going to model each outcome twice. So we're going to have models for any services overall, the three where we had a high prevalence of good data so we could do the modeling, mental health, social work, and dietitians, and then we're going to label everybody else together. We're going to model each one twice, one with the clinical data only, one with the clinical data plus the socioeconomic. We're going to do this on split samples for training and testing, and our approach is a random forest classification algorithm. And that'll tell us, helpfully, step us through to give us an idea of the contribution of everything. So let's look over the prevalence of any social service referral need. And I think in and of itself, this is fairly important. What we're looking at is what is the risk or likelihood that a patient should be referred to any social service? And if we just pull the data overall in our sample, 53% of the people in our sample were referred to a social service. That's quite significant. As you can see, nearly 20% to mental health, more than a third were referred to dietitians, and even social workers had nearly 10%. So there was a high demand and high use of these services within a healthcare system. You know, this is stuff that physicians and nurses normally aren't trained to deal with and work with, and so it really helps having these additional staff available to address these kind of needs. So prediction services, this is the results. This is the area under the ROC curve, if we're familiar with that statistic. We have ranges of about 0.74 or 0.71 to 0.78. that is the overall performance of our models. For the clinical data only, to put that into context, that's about what you would see for models that do mortality prediction, readmission prediction, disease development prediction, care coordination prediction. And according to the literature, this kind of performance falls under the useful range. Now, that's the clinical data only. When we add the public health data and the socioeconomic, we actually see no effective improvement. What we found. We got our performance with the clinical data, and when we add to the social, economic, and public health data, we actually did not improve. In some cases, the model performance actually decreased a little bit. To make this easier, I'm going to show this graphically so you can get a feel for this in terms of sensitivity, specificity, accuracy, and positive predictive value. The blue is the clinical data only. The orange color is the clinical data plus the socioeconomic data. And as you can see, we don't have any real changes in performance that are statistically meaningful, and even to an extent a little lower. So overall, the models perform okay. However, the addition of the socioeconomic data didn't help out that much. So what are some limitations about what we've seen? Well, as you could tell, most of our socioeconomic measures and social determinants health measures were at the aggregate level. We are dealing with one metro area, but it's still aggregate levels, and so therefore we may not have a lot of variation going on within our single metro area. The kind of individual measures we'd love to have about personal income, employment status, those things are not always available for EHRs. So we have to default to areas. But we probably did not have enough precision in those measurements to help out and to improve model prediction. We also have a very high-need, vulnerable population. This is a safety net population, so it probably has a lot of limited generalizability to other settings. And truthfully, though, too, there's probably a lot of unmet need anyway. So a lot of folks who are high risk would benefit from these services, regardless of prediction status. Something that definitely does limit the generalizability of this to other settings is the fact that these were all co-located within primary care. We did not talk about predicting referrals to other social services or government agencies. That would be something not only a different workflow, but probably a different approach to modeling. And we actually don't have any assessment of whether or not a prediction to a referral was even appropriate or the person kept it. We just used that as our outcome for modeling. Now, that's all what we've been working on to build these models. So what's the next step? Well, the next step is actually try to help identify patients who need referrals and facilitate their referral within Eskenazi Health. So right now these are live. We have a pilot of this running live. Every morning Eskenazi Health sends to the Regan Street Institute a registry of their appointments for the day. We run it through this prediction algorithm. The results are sent back to Eskenazi Health. And right now it comes in as a Excel spreadsheet or comma-separated file that is shared among the nursing staff and these other social service providers at their each clinic site, where it gives a listing of the patient, some identifiers, the provider the patient is set up to see, and the predicted risk probability for each patient who needs a service or not. We give both the overall predicted probability, but we also scale it into a easier to read low risk, rising risk, or high risk for referrals to set. And so this is given to the staff for them to use to help identify patients they might want to visit with during the day or for day planning. And we're actually in the midst of evaluating our rollout of this. We collected baseline data on referral rates overall, and we rolled out 3 clinics live in kind of a stepped wedge design. In the summertime, we waited 2 months, rolled out the next 3 clinics, and this fall in October, we rolled out our last 3 clinics. And so all 9 clinics have been going live for multiple months now, and we actually are now in the process of analyzing the data to see if providing this extra information was associated with any increases in referrals to these services. This stepwise design allows us to have control groups going on at the same time from the organization, and we can also use the historical data to look for changes before and after. So in summary, we're using predictive modeling to identify patients who are in need of social services. We have indications that predictive modeling for social services may be useful. We were in the what was considered the useful range for predictive models based on our ROC curve statistics. We have models that leverage both EHR and HIE data, and clearly we can improve performance, but our performance was consistent with what one would expect in the literature. And the important takeaway is our implementation of socioeconomic and public health measures, which are all at the aggregate level, did not improve model performance. And with that, I thank you all for your attention, and I will turn it over to my colleagues.
So thank you, Josh. And before I introduce our commentator, I would like to remind everyone again that if you have questions about the presentation, please do type your questions in the chat box, and we'll try to get to them after at the end of the webinar. So our commentator for today is Dr. Michael Schaffer, who is a professor in the School of Social Work at Arizona State University's College of Public Service and Community Solutions, where he also holds affiliate appointments in the Center for Health Information Research and the School of Criminology and Criminal Justice. Michael is the founding director of the Center for Applied Behavioral Health Policy, which has, for the past 25 years, conducted cutting-edge research on the adoption and implementation of innovative practices in behavioral health care. Michael has authored more than 40 peer-reviewed research articles and generated more than $45 million in grants and contracts that target capacity building and innovation in behavioral health services. He has received numerous awards and citations, including recognition from the U.S. Department of Justice for the development of crisis intervention training for law enforcement personnel. He is also a frequent contributor to professional literature, and he consults with behavioral health agencies throughout the country. So with that, I'd like to turn it over to you, Michael, for your comments.
Thank you. And first of all, I want to apologize for somehow getting the marketing version of my bio into you. It's a bit much. I want to compliment Josh and his colleagues at Indiana for the work that they've been doing. The utilization as healthcare reform has rapidly evolved in the last 8 years as a result of a lot of the health informatic drivers that came about as a result of the Patient Protection and Affordability Care Act has made the possibility for the kind of research that Josh is engaging in much more possible, and it mirrors in many ways some of our work that we're doing here with Robert Wood Johnson funding. So personally, professionally, very intrigued with the models and approaches that you've taken on here, Josh, and I know that there's been a robust amount of research in predictive modeling, primarily around healthcare. And I think that one of the things that intrigues me about your work and about the culture of health initiative of RWJ is beginning to reconceptualize health and the delivery of healthcare beyond the bounds of medical care and healthcare delivery. And I think your steps toward trying to better conceptualize some of the drivers both at the patient level and at the community level that may predict and perhaps facilitate or promote a referral to an adoption of social services is significant. I think it benefited from being able to work with a partner, who is as large as your partner is, so it provides a rich, deep database and multiple levels potentially of analysis across the various lines of business, clinics, settings that this health plan operates. I think you rightfully noted that some of the other systems involvement of this patient population were some of the shortcomings of things that you haven't been able to build in at this point. And I will tell you, I struggled a little bit, Josh, as your conceptualization around social services and your identification. One, I love the model, the social determinant heuristic model that you've adapted and applied here. But as someone who's done a lot of work in the substance use area and the behavioral health area, identification of smoking and substance abuse as personal behaviors as opposed to health status around addictive disorders, I suspect that conceptualization may meet with some resistance or some nuance need, I think, as we consider the behavioral health profile. Likewise, I mean, this whole idea of how you use your claims data and your EHR data to first of all identify who's getting social services, and then can we create algorithms that our providers and clinicians can use to flag individuals in need of those services is just terribly provocative. When I think of social services, though, again, I would imagine our psychiatrist and psychologist colleagues might take some umbrage that they've been relegated to a social service rather than a health service, and I think it reflects, right, some of the current dynamic, both at the practice level and the policy level, around healthcare integration. I see this separation in some of your conceptualization between mental health and substance abuse as opposed to an integrated orientation to how we conceptualize, or how you conceptualize behavioral health services, an area that had me thinking a little bit. And likewise, the identification of a referral to a dietitian and to dietetic services as, again, as a social service as opposed to a health service just kind of stimulated me a little bit. So I'd be interested in hearing more about your thinking in that area. And I think you rightfully noted, again, as I pointed out, that acknowledgement of limitation on being able to track service referrals and service activity outside of your health plan. When I think of social services, and particularly working with this population, the two social services that I think are probably some of the most priority in that social service realm, and particularly as it relates to social determinants of health, are housing and housing assistance services, and then employment and job placement assistance. So I don't want any of that criticism to be hypercritical, because I really do think the work that you're doing here, Josh, you and your colleagues, should be commended, and I think you've got a wonderful research environment, both with your partner and the statewide AIT Health Information Exchange, that I think provides a great research action platform. And with that, I'll open back the floor.
Thank you, Michael, for your comments. And before we get to the questions, which again, remind everyone, if you have questions, please do type them in the chat box, and we'll get to them at the end. We'll try to get to them at the end. So we want to first turn it back to you, Josh, so you could respond to Michael's comments.
Yeah, so I definitely appreciate Michael's thoughtful analysis and commentary on what we've done. And he has raised many questions that we have struggled with ourselves. There's two I'm going to talk about, although he's mentioned many other things that are highly relevant, particularly the connections to outside organizations. I would definitely agree is a really important concept and one that's a particular challenge for health systems to understand how to link and work with others. And at the same time, for how other organizations that have not traditionally worked with healthcare organizations to partner with them in an effective manner. I'll leave that one aside because we haven't addressed that, but I think that's a really important area that I know others are working on. The first one I'll mention is we have struggled with labels on this quite a lot. What we're really, and conceptually, we really are looking for those services that are non-medical, but really address a lot more kind of the social determinants of health and the drivers of, medical utilization. So that's what we've been working with. We've bounced around and called them social services, knowing true that that's not totally accurate. That's not fair. We've called them social determinants of health services, but that seems to be getting a little wordy. So we've had trouble with that. Our partners at Eskenazi call them wraparound services. And I like that because it's pithy, but wraparound services has a history in pediatric care, actually pediatric psychiatric care, I believe. And so it has that term is kind of laden a little bit as well, and it also has some Medicaid implications. So while we've been struggling with that, and we don't like to call anything by negative, so this is really like all physician, nurse practitioner, clinical care. We've been struggling with those labels, and more than and everything Michael mentioned is stuff that we've wrestled with too about the accuracy of it. And not to excuse us or to be in our defense, the literature seems to be struggling with this as well, of coming up with what we should be appropriately gone with. For shorthand purposes, we've actually moved more towards just calling them wraparound services because that's how we talk around here anyway, but knowing that in itself has limitations as well. The second part that Michael mentioned I think is really important is the measurement of referrals to these services. And this is going to be true whether it's referrals to somebody in-house or referrals to some external organization. Finding the documentation of these things is hard. There's just no way around to say it. It's challenging. Mental health's in a better state because people were billing for that. But historically, there's been nobody to bill for a social work encounter. There's been nobody to bill for navigation, or it's not been really on anybody's radar to bill for these things, if possible, with certain plans. So without that kind of financial incentive, these things are frequently undocumented. We would come across the setting frequently that even sites that have, say, a social worker, it would frequently be somebody would pop out there, lean out the door and shout, hey, can you come down and visit with this patient? It wasn't anything that was done through official documentation channels. So it's a challenge. We actually have done a work on this. We published recently a paper talking about how we were able to identify these both through structured and unstructured data. And the basic upshot is you can use structured data to find referrals to these services. There's codes that exist and can help you out. But unless you move to the unstructured notes within an EHR and the actual order text themselves, you're not going to find everybody. And not only are you not going to find everybody, the people who are documented in notes tend to be sicker and more complex. And so that runs into a challenge of how you actually go through and measure all this. It requires an effort and a fairly thoughtful strategy, which unfortunately in the current state of our EHRs is probably fairly idiosyncratic per institution. So that's another warning, but a definite challenge out there for anybody who wants to start. The first is just how do you go out and measure these.
All right, thank you, Josh. So we have some time left in our webinar, about maybe 15 minutes to go over some of the questions that have been posted. So I'll help walk you through them, Josh. So our first question would be from David. There's the finding of no improvement in ROC, which is the receiver operating characteristic, by adding area variables diminished support for the premise that place determines health. nobody's ready for this null finding, and it is not due to small sample size. An alternative method would be a multi-level model regression with an F-test and area variables. Did you try that?
So on the first, we ran through and looked at the association in multiple ways. I have to go through and know exactly which testing we approached to look at it. But I think the challenge for us is I'm a firm believer that the evidence indicates that place makes a heck of a lot of difference, right? I think in our study setting, we are limited by the fact of we only have one place. And that one place, because it's serving a safety net population, it doesn't have as much variation. If we were to extend to, as we hope to do in the future, to multiple institutions who serve a broader base and varying types of socioeconomic conditions, I bet we would be able to see that information pop out in a more robust way. But for right now, I think it's basically there's just not enough variation in the sense of we're making distinctions between low and lower areas of socioeconomic status versus areas of low versus high socioeconomic status in our models.
All right. Takesha has a question. Is it that the information on the social side was not granular enough that you were not able to make the predictive modeling effective? That is, since you had to use aggregate data and not person-specific data, it wasn't meaningful enough?
So I think on the aggregate data, so aggregate area socioeconomic conditions, we are not in, so I want to make sure I'm being very clear on this part. We are not imputing socioeconomic position or status to individuals based on area measures. Area socioeconomic status is a different construct than individual personal, for example, socioeconomic status, right? We'll pick an example, right? I can be living in a high income area but still very low income, right? So the implications of my personal socioeconomic status and social determinants of health are different than the areas that I live in. Now, both of them have a role, and I would definitely agree with the questioner that the personal ones are probably much stronger and more direct, but overall context is important. I think what it is in our context, we just don't have enough variation and variability at our level to see what is really that level of area import.
All right. So I guess it's related to that. Anne asks, if the predictive model shows no statistically significant change between the models, how do we move forward in adding the SES factor into our healthcare data?
So I think one is in ours, we're hopefully going to get a broader set. We'd like to expand and include and look at more different types of patients. So that would be one setup to look to see how we include it and to really assess the amount of variation we have. The other is looking for ways to extract socioeconomic, socio-determinant health indicators from the clinical record themselves. So those kind of indicators actually getting to the person-level measurement. And I know the Institute of Medicine is working very hard to make recommendations on what levels of social determinants of health or what indicators of social determinants of health should be incorporated into EHRs and should be available across.
Theresa has a question. Is the underlying assumption that increased referral is a good thing? Is that what your ultimate impact is, to increase referral to mental health and social work? Not sure that a particular diagnosis should indicate referrals to either. Also, are you measuring the model's ability to predict if providers will refer or if the patient is in need of a referral?
So the overall goal is to connect patients more effectively and efficiently. So if we sit there and think about let's make a couple of assumptions and take them for granted based on the literature, that the social determinants of health influence health. They're important to a person's overall health status. As we sit right now in the healthcare environment, we're not structured well to address them. Patients, when they come into a healthcare encounter, see providers who are very well trained but they're well trained in medicine, not in the social determinants of health. Not only are they not trained in them, they're not necessarily given the tools by their organization to address them. So there is an initial challenge or barrier to actually even identifying them from the provider side. Second, providers don't have a lot of time. We all know that. And social determinants of health problems are very challenging. They're complex. They require a lot of activity and action, and that's something that really can't be handled in an office visit. And then the last one, social determinants of health actually can be somewhat uncomfortable. Patients may not like disclosing their difficult contexts and situations. Fine. If we work on those assumptions, but we still know that patients need these services addressed and taken care of, how can we better get these patients to the people who are equipped with the time, the skills, and the connections to address these challenges? And that's what we're hoping to do, is can we just identify these folks first more effectively for them? Now, in our current intervention and rollout, we're doing the identification. We are not identifying patients at risk for referrals or in need of referrals. We haven't set up default orders or anything like that. We are providing basically what we like to tell our partners, another data point for people to make their assessments and reviews themselves. This is just an indication for folks that may not be immediately obvious or may fly under the radar. And that's part of the other part of the question is this is also part of the machine learning approach here we're doing with this random forest stuff is not truly deterministic. It is the total profile of everything going on. So it's not necessarily one diagnosis that says, oh, you should be referred to the nutritionist. It's a combination of a whole bunch of factors. As we said, it's 41 clinical factors that go into it, and the other factors that are available as well, to help really get the entire picture for how much do you look like somebody else who's gotten these services in the past. That's kind of the overall approach. Now, as we roll out, we want to see improvements in referral rates because we think the services could be used more effectively. On top of that, we want to actually look for appropriate referrals. We want to look at retention. Do patients who refer to these services actually, stick with these providers over time, indicating that they should have been referred to them and it was the right match? So those are kind of the outcomes we're looking at in the long term after we can hopefully demonstrate that this was able to function and run and be used in a clinical setting.
All right, so I think we have time for 3 more questions. I'll start with David. If it relates to that previous question, will you be able to describe how much of the probability of need for referral varies across levels of predicted risk?
Will you be able to describe how much the probability of need referral varies across? I'm not exactly sure what that question is asking for. I mean, we can, because it's got probability of need and predicted risk are both the same in my mind. How much the probability of need for referrals vary? We can describe the variation. Let's rephrase that. So part of our thing is we can describe the variation in terms of the predicted probability and its accuracy and how well it's working. We can also describe and stagger out. There's nothing that stops providers from referring people regardless of our risk scores. We've been very clear with that as well. Clinical judgment is not being trumped by this. This is not default referrals. This is not automatic orders. This is an extra data point. So we will be able to track over time who was referred, who was not indicated as high risk, and we can follow up that as well. So we can see if there's any variation in that across our risk stratification, by stratifying out by high risk and low risk. Okay.
Nicole has a question. Have you considered partnering with area agencies on aging to address social determinants of health? If so, have there been barriers in establishing that partnership?
So we have not partnered directly with aging organizations as part of this project because our clinical partner, Eskenazi, actually has a very strong working relationship with our School of Medicine on healthy brain aging and an aging center. That they have a fairly strong connectivity to an existing cohort of geriatricians and mental health experts that they refer patients for already. The Eskenazi also participates, or also runs case conferences where they bring in a whole bunch of different providers, the members of the care team, and other organizations from the community to address particularly challenging healthcare organizations. And members of the aging and disability community have been part of those teams before. And so there already is work and referrals working to them externally, but we were not looking to tackle the external referral challenge with this project. That'd be the future.
All right, we've got from Ruth 2 last questions. Josh, have you considered the recommendations from Adler and Steed regarding data capture for social determinants as next steps for your research? And she also asked if your future research will move beyond screening for risk versus actionable information that can be used by the healthcare team.
So we would love to have more data on social determinants of health captured in the electronic health record. That would be phenomenal, and I know our partners are interested in having that data available as well. However, we're talking about the difference between a research project and changing the operations of a foundational information system for a large 300-bed hospital and associated clinics. That is changing the data collection structure right now is not necessarily feasible or possible with somebody who's operating a commercial EHR, for at least for our setting. But we would love to be able to extract more, and we're exploring more how we can get more out of the notes through using things like NLP and other options. So the next thing is, yes, we're using this to help risk identify. The goal, whether it be in 2.0 or 3.0 or 4.0, whatever we start building this out, is the progressive plan of research is to, one, move this from a batched external tool to a real-time internal tool to the electronic health record where any provider can go to a tab and see the individual risk scores for a patient. That's our goal. Moving on, once we have established that setup, we could move on to default ordering and pre-populated referral notices to make that transition even easier for the care providers. So yes, that's kind of our plan to move forward.
All right. Thank you so much, Josh, for graciously answering all these questions. I think there's a lot. Your presentation has really generated a lot of interest, and we do ask that if you have any questions, additional questions, please do forward them to Josh. And also the presentation for today is also available for download from the S4A website as well. There's also a project page for it. And so we'd like to thank again our presenter, Dr. Joshua Vest, and our commentator, Michael Schaffer, for their comments as well. And we also appreciate all the questions that you have sent in. And we'd also like to invite you to also our upcoming webinars too as well. So we invite you to take a look at that and also to join us in the future. So I think we have enough time to give back to you for today. So thank you again, Josh. Thank you again, Michael. And thank you again for joining us in today's webinar. We wish you all a very good day and a great start to 2018. Thank you so much.